20-year-old male patient complains of pain abdomen and vomiting since 2 months. He says the vomiting is 2 to 3 hours following food intake and contains undigested food particles. It is associated with generalized weakness and loss of weight as well. He says he passes dark, tarry, foul-smelling stools. On examination, a hard mass is palpable in the epigastrium, which falls forward on knee-elbow position, and succussion splash is positive. All these go in favor of a diagnosis of carcinoma stomach. So let us discuss briefly about carcinoma stomach. It is a major cause of cancer mortality worldwide, but highest incidence is seen in Japan, and that is why a lot of study regarding carcinoma stomach is done in Japan, as well as major advances in the field of stomach malignancies has been done in the country of Japan. Higher incidence is seen in male, and early diagnosis is a key to a effective treatment and management of carcinoma stomach. So what is the etiology? We know that one of the most important causative factors of carcinoma stomach is Helicobacter pylori. So H. pylori has the ability to break down the mucosal barrier of the stomach. We know that the inner lining of the stomach is coated by mucus secreted by the mucin cells. This Helicobacter pylori has the ability, it has urease, which in turn splits urea into ammonia, and thereby it causes the breakdown of the mucosal barrier, thereby causing inflammation of the lining of the stomach, and this chronic inflammation can predispose to carcinoma stomach. So H. pylori is an important cause. Pernicious anemia, in the same way, in pernicious anemia there is inflammation of the stomach as well as gastropathy. Chronic inflammation of the stomach predisposes to carcinoma stomach. Gastric atrophy and gastric polyps. It might be a part of the familial adenomatous polyposis, where there are hundreds of polyps in the intestine as well as stomach, and that can turn out to be malignant. Peptic ulcer surgery. So we are not talking about peptic ulcer, we are talking about patients who have undergone surgery for peptic ulcer, like anastomosis, a gastrojejunal anastomosis. So here what happens is, at the site of anastomosis there can be reflux of contents into the stomach or into the site of anastomosis, and thereby that will predispose to carcinoma stomach. Smoking, cigarette smoking, again causing irritation to the lining of the stomach. Diet rich in salt or salted food, that can cause irritation to the lining of the stomach and thereby cause carcinoma stomach. And genetic factors all predispose to the development of carcinoma stomach. So the etiology is H. pylori infection, pernicious anemia, gastric atrophy, gastric polyps, peptic ulcer surgery, cigarette smoking, diet, and genetic factors. So pathology, how on gross does the malignancy appear? So it can appear like a cauliflower type of lesion, that is like a growth that is protruding into the lumen of the stomach. Ulcerative. So the cauliflower type of lesion can cause obstructive symptoms. If it is present at the pylorus, it can cause gastric outlet obstruction. Ulcerative. So this ulcerative presents more commonly as bleeding. These ulcers silently bleed from its surface, and thereby patient will present with pallor, will present with melena. So ulcerative type. And another form of carcinoma stomach, where the entire stomach becomes like a hard mass which cannot distend. It becomes like a leather bottle, and that is known as Linitis plastica. So grossly, the growth in the stomach can be cauliflower type, ulcerative type, and leather bottle type, what is known as Linitis plastica. Besides this, it based on the type of cells. That is, so far what we spoke about, the pathology was the gross pathology. Depending on the histology, the type of cells, it is divided into gastric adenocarcinoma. Obviously, the most common malignancy because of the columnar lining of the stomach, 95% will be gastric adenocarcinoma. About 4% can be lymphoma, and the rest are very minute gastrointestinal stromal tumors. The growth doesn't even arise from the mucosa, it comes from outside, from the serosa. So gastrointestinal stromal tumors, leiomyosarcoma, squamous cell carcinoma, adenoacanthoma, and carcinoid tumors are rarely seen. So these are the different types of malignancies based on the histology. The same thing is classified by WHO. So there are a number of classifications when it comes to carcinoma stomach. So here comes the WHO classification, which takes into the account the histology. Next, there will be the Lawrence classification, where it will base the classification on type of malignancy, whether it is intestinal or diffuse. Then come the two classifications, the Japanese classification and Borman's classification for early gastric carcinoma and advanced gastric carcinoma. And the last one, the Sievert's classification, which can either you can discuss it in esophagus or in stomach. So number of classifications very important in case of carcinoma stomach. So first coming to WHO classification. So already we spoke about adenocarcinoma, the most common one, 95%. So this adenocarcinoma can be papillary adenocarcinoma, tubular, mucinous, and signet cell ring cell type of adenocarcinoma. So these are all the adenocarcinomas that can occur in the stomach. Besides this, we already said there can be adenosquamous, squamous cell carcinoma, small cell carcinoma, and undifferentiated carcinoma. So the WHO classification based on histology of carcinoma stomach is divided into adenocarcinoma, which is further divided into papillary adenocarcinoma, tubular adenocarcinoma, mucinous adenocarcinoma, and signet ring cell carcinoma. Besides this comes the adenosquamous features of both adenocarcinoma as well as squamous cell carcinoma, pure squamous cell carcinoma, small cell carcinoma, and undifferentiated carcinoma. So the first classification is done. Next, we come to Lawrence classification. This is the most favorite or the most useful clinical pathological. It divides the carcinoma stomach into two types. One is intestinal type and second one is diffuse type. From the word intestinal type, already we know this is a malignancy that is related to stomach. It is carcinoma stomach. We are saying intestinal type, so there must be some reason due to which the stomach mucosa is resembling that of the intestine, and that is known as intestinal type of malignancy in carcinoma stomach. The gastric mucosa is replaced with the epithelium that resembles that of small bowel mucosa, and most commonly the culprit is H. pylori, and that induces the transformation, the metaplasia of the gastric mucosa into that of intestinal small bowel, and that is known as intestinal type. It has a good prognosis. So this type of malignancy, the intestinal type of malignancy from Lawrence classification, has a good prognosis. On the other hand, there is another one called as diffuse, which we have already discussed grossly when we spoke about Rhinitis plastica or leather bottle appearance. Early gastric wall penetration and both submucosal and serosal lymphatic spread. So it already spreads early into the walls of the stomach. There is lymphatic as well as submucosal spread. It is a poorly differentiated malignancy, and it is Rhinitis plastica, ulcerative growth without glandular formation is common. And unlike intestinal type, this has a poor prognosis. So intestinal type, the mucosa of the stomach is replaced by that of the small bowel, and that is induced by H. pylori. And diffuse type, there is early gastric wall penetration, the stomach becomes hard, cannot distend. How much ever on endoscopy, how much ever gas is inflated, the stomach will not distend. The rugosity of the stomach is lost. It has poor prognosis, and that is diffuse type. So Lawrence classification, important clinical pathological classification dividing into intestinal and diffuse type. Next, we come to two important classifications. One is for early gastric carcinoma, that is Japanese classification, and then for advanced carcinoma, that is Borman's classification. So when we talk about Japanese, we remember early gastric cancer. So early gastric cancer, and both these classifications are based on the depth of invasion. So it depends on how much the tumor has invaded into the walls of the stomach, edges, the lining of the stomach. And since we are talking about early gastric carcinoma in Japanese classification, we are talking about the layer which is superficial to the muscle layer. We know that the stomach is lined by epithelium, followed by basement membrane, followed by lamina propria, then comes muscularis mucosa, and then comes the mucosa. Below that comes the muscle layer, that is the muscularis propria, which consists of circular muscle layer and longitudinal muscle layers. So in early classification, we are not talking about the muscular layer at all. We are talking about all the layers superficial to the muscular layer, that is up to the submucosa. The moment it goes into the muscular layer, then we go into Borman's classification, which is advanced malignancy. So early gastric cancer, Japanese classification involving the mucosa and submucosa only, with or without involvement of lymph nodes. So how is it divided? Type 1, type 2, A, B and 2C, and type 3. So type 1 is a protruding type of lesion. Forget about how deep it's gone. It is a protruding type of lesion into the gastric lumen. Type 2A is superficially just mild elevation. So again, just elevation from the mucosa. Type 2B is superficial flat. There is no elevation. It is a flat lesion. Type 2C is superficial depressed. Again, all these are within the submucosa. It is not gone into the muscle layer. And type 3 is an excavated lesion. Again, not going beyond into the muscle layer. So type 1 protruded. Type 2A superficial elevated. Type 2B it is flat. Type 2C is depressed, and type 3 is excavated. So this is Japanese classification. So in Japanese, we finish early malignancy. Then we'll go to Borman's classification, which is advanced malignancy. So this is for advanced gastric cancer, involvement of muscularis and serosa. Now we are going into the circular muscle layer and longitudinal muscle layer and the serosa. Again, with or without involvement of lymph nodes. Usually type 3 and type 4 are incurable. So again, now we are coming to type 1. It is polypoidal, but it is involving the muscle. Then comes ulcer with clean margin involving the muscle layer. It is ulcer with nice clean margin, like a nice U bucket shape. Then comes ulcer without clear margin. So it is gone very irregularly. So without clear margin involving the muscle layer. And diffuse type just goes wherever it wants, involving a lot of length of the muscle. So again, polypoid involving the muscle, ulcer with a clean margin, ulcer without a clear margin, and a diffuse type can even be a rhinitis plastica, which is involving the entire muscle layer of the stomach. So that is about Borman's classification, which is involvement of muscularis and serosa with or without involvement of lymph nodes. Next, coming to Sievert's classification. Sievert's classification can be discussed both in esophagus as well as stomach, because it is a malignancy that arises at the gastroesophageal junction. So we'll come from the stomach, from the esophagus down to the stomach. It is divided into 3 types: type 1, type 2 and type 3. So we know that if this is the esophagus, stomach, and then this is the gastroesophageal junction. Normally the epithelium of the stomach is lined by squamous epithelium, and that of the epithelium of the esophagus is lined by squamous epithelium. The epithelium of the stomach is lined by columnar epithelium. However, due to repeated reflux, the lower part of the esophagus is turned to columnar epithelium. The esophagus is adapting to the acidic secretions coming into the lower part of the esophagus, and that is known as Barrett's esophagus, and that can turn into malignancy. So type 1 in Sievert's classification is adenocarcinoma of the distal esophagus. Now we are in the distal esophagus, arising from Barrett's esophagus. We already spoke about Barrett's esophagus, and may infiltrate the esophagogastric junction. So from the lower part of the esophagus, it may infiltrate the esophagogastric junction. It has not entered the stomach. In type 2, it is adenocarcinoma at the cardia, that is the junction between the stomach and the esophagus, arising from the epithelium of the cardia or from intestinal metaplasia of the esophagogastric junction. Now we are coming slightly lower. From the lower part of the esophagus involving the gastroesophageal junction, in type 2 we have come to the cardia, lower part. In type 3, it is adenocarcinoma of the subcardial stomach. So now we have come starting at the stomach here, we have come into the stomach, which may infiltrate. Now we are talking about the malignancy going upwards, which may infiltrate the esophagogastric junction or distal esophagus from below. First one was coming from above. The second one was at the cardia. It can go either way. And the third one is type 3 adenocarcinoma from the subcardial stomach. From the stomach, it goes upwards and may involve the esophagogastric junction. So this is known as Sievert's classification. Then coming to the common sites where we see gastric malignancies. So pre-pyloric and pyloric region, most commonly it is seen here in the pre-pyloric, that is the distal stomach, in the body around 25%. And even though we say that only 10% of the malignancies are seen in the proximal part of stomach, now in recent years, there are more development of carcinoma stomach in the proximal sites than in the distal. Number of cases of proximal site malignancies are increasing in the last few years. But the most common site is pre-pyloric, then comes the body, and then comes the proximal stomach. What are the clinical features? Now there can be a cauliflower proliferative growth in the stomach. There can be an ulcerative growth in the stomach, or the stomach can become very rigid like a bottle, leather bottle. So we already said that. So the clinical features will be based on that. Early satiety. So if there is a cauliflower growth in the stomach, that itself will occupy some space in the stomach. So when the patient eats food, he will feel full easily. So early satiety. Bloating and distension. If there is gastric outlet obstruction, there is a growth at the pylorus which is not allowing the food to go into the duodenum. So the patient consumes food, there will be distension of the stomach, what is known as GOO, gastric outlet obstruction. There will be dysphagia. If, like we discussed just now in Sievert's classification, there is a growth there at the gastroesophageal junction from the cardia of the stomach going upwards, type 3. It is occluding the lumen of the stomach. Patient will not be able to eat food. That is dysphagia. Patient will have vomiting. And this vomiting in carcinoma stomach depends on what type of growth, where is the growth. If the growth is at the pylorus, causing gastric outlet obstruction, which is not allowing food to go into the duodenum, patient will have food. After 2 to 3 hours, patient will have vomiting of undigested food particles. This is because gastric emptying time is usually 3 to 4 hours. So food will be there for 3 to 4 hours. It will attempt to go into the duodenum. It is not happening. So patient will have vomiting after 3 to 4 hours of consuming food. If it is an ulcerative type of growth, then there will be bleeding. Patient may have blood in the vomiters as well. So from the type of vomiters, we can know what type of growth where. If it is Sievert's type 3 with the growth at the cardia of the stomach which is going upwards, patient may have food vomiting immediately after consuming food because it is not going down, it immediately comes back. Or there might be other forms of vomiting where there are other symptoms like dysphagia, difficulty in swallowing. Iron deficiency, anemia. Ulcerative growths in the stomach will slowly bleed over time. Constantly they will be losing blood little by little, and over a period of time, 2 to 3 months, patient will develop iron deficiency anemia. On examination, pallor will be present, and because the patient is not able to have food, patient will have profound loss of weight. So clinical features of carcinoma stomach are early satiety, bloating and distension of the stomach, dysphagia, vomiting, iron deficiency anemia, and profound weight loss. What are the signs? On examination of the patient, we'll see a visible gastric peristalsis. Now the stomach is lying obliquely going from left to right. Normally when food is there, the stomach will have peristalsis from left to right and it will push the food into the adjacent duodenum. If there is a growth there which is not allowing the food to go, the stomach will push and that peristalsis will be visible. That peristalsis is so powerful that we can see it from the skin, from superficially, that the peristalsis is moving from left to right direction, and that is known as visible gastric peristalsis. Ausculto percussion. On doing ausculto percussion, on keeping the stethoscope in the epigastrium and doing percussion and auscultation, we will be able to know that the stomach is hugely distended. It might go even up to the umbilicus because of gastric outlet obstruction and the contents within the stomach. Succussion splash. 2 to 3 hours after the patient has had fluid, if the stent is placed on the patient's epigastrium and if the patient is shaken, the fluid, the gurgling of the fluid will be heard. That is known as succussion splash, an indication of gastric outlet obstruction. A palpable abdominal mass, a hard mass in the epigastrium which falls forward, which moves up with respiration along with the diaphragm can be seen. Palpable supraclavicular lymph node when it spreads to the left supraclavicular node, what is known as Virchow's node. Palpable periumbilical node, what is known as a lump around the umbilicus, what is known as Sister Mary Joseph node, can be palpable, and peritoneal metastasis may be palpable parectally. On parectal examination posteriorly, some mass may be felt. That is nothing but the peritoneal deposits that form there, what is known as Bloomer shells. So these are the signs seen in carcinoma stomach. And then come the features of metastasis. What are the features of the spread of disease? So there can be Trousseau syndrome. This is also known as migratory thrombophlebitis. There will be inflammation of the superficial veins. It can be, it migrates. It can be of the thigh. Later it will go to the leg. Later it might spread to the arm. The superficial veins are thrombosed, they are inflamed, they are tender. This is mainly because these malignancies cause a hypercoagulable state and there is clotting of blood in different vessels of the body. So that is known as migratory thrombophlebitis, also known as Trousseau syndrome, because of hypercoagulability induced by malignancy. There can be Bloomer shelf, I already said, the palpable peritoneal deposits parectally. Spread to the transcelomic spread to the ovaries in females, what is known as Krukenberg's tumor. Palpable left supraclavicular lymph node, what is known as Virchow's node. Sister Mary Joseph node because of spread through ligamentum teres to the umbilicus. And jaundice when there are secondaries in the liver. Liver is palpable with hard nodular secondaries with umbilications present, and ascites, which is a sign of advanced malignancy. So these are all the signs of metastasis that can be seen in a patient with carcinoma stomach. Then we come to the all important TNM staging of carcinoma stomach. So T for tumor, N for node, M for metastasis. TX, primary tumor, cannot be assessed. T0, no evidence of tumor. TIS, carcinoma in situ, that is intraepithelial tumor without invasion of the lamina propria. So it has involved the epithelium, involved the basement membrane, but there is no involvement of lamina propria. That is the next layer. The involvement of lamina propria starts T1. So T1 is further divided into T1A and B. What does T1 involve in general? So T1 tumor invades the lamina propria, the muscularis mucosa and the submucosa. So T1 is not invading the muscle layer. Rest of the superficial layers it is involving. It is involving the epithelium, it is involving the basement membrane, it is involving the lamina propria, it is involving the muscularis mucosa, it is going up to submucosa, that is T1, except the muscle layer and serosa. So that way T1A is involvement of lamina propria and muscularis mucosa. T1B simple involves the submucosa. Now in T1 we have reached up to the submucosa. Then we come to T2. The next layer will be the muscle layer. Invades the muscularis propria, that is the circular muscle layer and the longitudinal muscle layer. Then comes T3, invades the subserosal layer. So it goes beyond the muscle layer, beyond the longitudinal muscle, then comes serosa. It does not invade the serosa, it comes deep to the serosa, that is subserosa. So invasion of the serosa and goes up to the subserosa but does not involve the adjacent structure. Then comes T4. Again, the general T4 is tumor penetrates the serosa. Till now we were in subserosa, where tumor invades the serosa or it invades the adjacent structures. So again, now it becomes simple A and B. T4A penetrates the serosa, visceral peritoneum, and T4B, it goes beyond the serosa and invades the adjacent structures. Then coming to the end stage. So NX regional lymph nodes cannot be assessed, N0 no regional lymph nodes. Then we come to N1, N2, N3, which is divided into A and B. N1 is metastasis to 1 to 2 regional lymph nodes. N2 is the metastasis to 3 to 6 regional lymph nodes. N3 is metastasis to more than 7 regional lymph nodes, which is further divided into A and B, that is 7 to 15, the A, and more than 16, it is divided into N3B. So N1, 1 to 2 regional lymph nodes, N2, 3 to 6 regional lymph nodes, N3, more than 7, which is further divided into A, which is 7 to 15, and 3B, it is more than 16. Metastasis, if there is distant metastasis, it is M1, otherwise it is M0. So the same thing to see the T staging of the TNM staging. So we can see that here T1A and this is T1B. It is not going up to the muscle. T2, involvement of the muscle. Important point to remember, carcinoma in situ is up to the lamina propria. It doesn't go beyond the lamina propria. That is, then T1 starts with involvement of the up to the lamina propria and submucosa. Then comes T2, which is the involvement of the muscle. T3, it is going, you can see here, the serosa is not getting breached, it is subserosal. T4A, it is going into the adjacent structure, it is going beyond the serosa, and T4B, it is going here into the adjacent structure and involving the duodenum. So this is the how the disease progression is seen in case of carcinoma stomach. And when we are talking about adjacent structure, it can be spleen, transverse colon, liver, diaphragm, pancreas, abdominal wall, adrenal glands, kidney, small intestine, and retroperitoneum. So this is the TNM staging of carcinoma stomach. Then coming to the spread, we already spoke about a little bit about the spread in the TNM staging. Carcinoma stomach can have direct spread, lymphatic spread, blood spread, and transperitoneal spread. Direct spread horizontally goes along the submucosal plane and can involve the entire stomach wall, as in linitis plastica, where the entire stomach is involved. On the other hand, vertical spread involves the involvement of adjacent structures like pancreas, colon, mesocolon, and the liver. Then coming to the lymphatic spread, the lymphatics of the stomach are extensive and it can spread to the subpyloric, gastric, pancreatico-duodenal, splenic, celiac, aortic, and later last it can even go to the left supraclavicular node, that is the involvement of Virchow's node. So it can go to the subpyloric, that is below the pylorus. It can be gastric, it can be on the left and the right side. It can be pancreatico-duodenal, splenic, and celiac nodes. Blood spread, it spreads to the liver, lungs, and bone. And transcoelomic spread or transperitoneal spread, it can go and involve the ovaries in female patients, and that is known as Krukenberg's tumor, and also rectal secondaries with Sister Mary Joseph nodes and umbilical secondaries are seen. So this is how carcinoma stomach can spread. What are the investigations done? We know that it can be a proliferative growth, it can be an ulcerative growth. If it is an ulcerative growth, it can cause bleeding. So patient's hemoglobin has to be checked. It might be low, especially if the patient is feeling weak, generalized weakness, hemoglobin will be low. Barium study is done, so barium meal is done, and there are different findings that are seen in a barium meal in a patient with carcinoma stomach. So there will be irregular filling defect. So there is a growth. So when the barium goes there, the growth will show, since there is a growth, that part of the stomach where there is an obstruction may not fill adequately. So there will be irregular filling defect. There will be loss of rugosity, especially if there is linitis plastica. There will be delayed emptying of the barium. Now the barium has gone there, it has to empty into the duodenum. There is gastric outlet obstruction which is not allowing the barium to go from the pylorus into the duodenum. So there will be delayed emptying. There will be dilatation of the stomach. Again in carcinoma, the gastric outlet obstruction, there can be distension. There is decreased stomach capacity in linitis plastica. So the barium will fill like a pipe rather than a stomach is a bag. Rather than like a bag, it looks like a pipe when it fills. And there's a sign known as Carmen's meniscus sign. So here the margin, now if this is the stomach and if here there is an ulcer, so here the margin of the lesion projects outward from the ulcer into the gastric lumen. So the barium will come here, fill the stomach, but here the margin of the ulcer will project into the lumen of the stomach because of the barium filling the rest of the stomach, and that is known as Carmen's meniscus sign. So these are all the signs seen in barium meal findings. The other investigations that are done are ultrasound abdomen, and ultrasound abdomen will help to know that there is growth. There are features of intestinal or gastric outlet obstruction. It might even be able to spot ascites. The CT scan will give a more definite and accurate diagnosis, which will be able to know the exact site of the ulcer or the lesion, along with the presence of ascites, along with the presence of secondaries in the liver, along with the presence of any secondaries anywhere else. CT thorax in proximal tumors to see whether there is involvement of esophagus, laparoscopy to stage the disease, and when we do laparoscopy, not only will be able to see whether there is a spread to the adjacent organ, we can see the secondaries, we can see omental deposits and peritoneal deposits, and they can be taken for biopsy to prove that it has already spread. And PET scan will help to localize the distant spread. It can be a bony spread. The PET scan will help to identify spread to distant organ. But the most important investigation in a case of carcinoma stomach is endoscopy. So when we do a gastroscopy, we go and visualize the interior of the stomach. Once we visualize the interior of the stomach, we know whether there is an ulcerative growth or a proliferative growth, and exactly which part of the stomach the growth is there. Whether it is at the gastroesophageal junction, whether it is at the fundus, whether it is at the body, and whether it is at the pylorus. Wherever the growth is, we take multiple biopsy, and that is sent for histopathology. And thereby we know the exact location as well as the diagnosis in case of carcinoma stomach. That is the gold standard now in the identification of disease in carcinoma stomach. Along with that, recently endoscopic ultrasound also is done, where endoscopic ultrasound can be passed into the probe, can be passed into the stomach. Not only will be able to know the growth, not only will know how much of the stomach wall has been involved by the growth, the adjacent lymph nodes can be detected as well. Once all these investigations are done, then we go to the treatment. If it is an early lesion, then EMR, that is endoscopic mucosal resection, is done. So as the name suggests, it is not a deep tumor, it is only involving the superficial layers of the stomach. So here it is done in tumors less than 2 centimeters, tumors which are elevated, which are well differentiated tumors without nodal metastasis. So here the scope is passed, the resection of the tumor is done deep to the mucosa, endoscopic mucosal resection. So the mucosa is removed completely and the defect is left behind with a negative tumor margin below. So this is done for very early tumors. This is known as endoscopic mucosal resection. Then coming to advanced malignancy. Now there is a growth in the distal part of the stomach. Then a subtotal gastrectomy can be done. Distally placed tumors. The proximal stomach is preserved. So distal part of the stomach. So if the growth is here, the adequate part of the stomach along with adequate margin. There is no point removing only the part of the stomach where there is growth. The spread can be into the adjacent part of the stomach as well. So with adequate margin, the stomach is resected. The proximal part of the stomach is left behind so that the blood supply comes through the short gastric vessels, which are the branch of splenic artery. And then now this part of the stomach is removed. This is the part of the stomach that is left behind. The stomach is closed from the lesser curvature towards the greater curvature. So it is closed from here and so much of the stomach is left open. So stomach is closed from the lesser curvature to the greater curvature and so much of the stomach is left open. Then a loop of intestine, that is the jejunum. Now this is the duodenum here, the stomach was here, the duodenum also has been closed, duodenum comes, jejunum. The jejunum is now cut here and the distal part of the jejunum is brought up and anastomosed to the stomach. So again, this is the duodenum which has been closed, duodenal stump has been closed, it goes into the jejunum is cut there, the distal part of the jejunum is brought up and anastomosed to the stomach. So all the contents from the stomach will now go into the jejunum. There is a proximal part which is cut, that is anastomosed to the other limb of the jejunum. So the jejunum is coming down now and the proximal limb is anastomosed here, what is called as a jejunostomy. So closure of the stomach from lesser curvature, and this anastomosis where the stomach is anastomosed to the jejunum is called as Billroth anastomosis. If the stomach is directly anastomosed to the duodenum, then it is called as Billroth 1. So anastomosis to the duodenum is Billroth 1. Anastomosis to the stomach where only small part of the stomach is there, it can't be reached to the duodenum, then it is called as Billroth 2 gastrectomy. So this is known as subtotal gastrectomy, done in case of distally placed tumors. Then coming to total gastrectomy. So here the stomach along with the greater and lesser omentum along with D1 or D2 lymphadenectomy is done. So here you can see the stomach was supposed to be here. This is the duodenum, this is the esophagus. The entire stomach is removed. The greater and lesser omentum is removed. So now what to do? The esophagus is lying here open. Food has to go somewhere. The duodenum has been closed. So same way, the duodenum has been closed. It goes here, becomes a jejunum. The jejunum is cut, transected, and the distal part of the jejunum is brought out from behind the intestine, behind the colon, upward, and anastomosed to the esophagus. So it is esophagojejunostomy. And the proximal part of that jejunum is anastomosed to the distal part here, what is known as jejunostomy. So Roux-en-Y esophagojejunostomy. Roux-en-Y esophagojejunostomy is done. Adjuvant chemotherapy is given. Malignancy, usually it is done in case of malignancy of the body or linitis plastica where the entire stomach is involved and nothing can be done. Aggressive proximal tumors, again this is an indication. The point about D1 and D2 lymphadenectomy. So D1 lymph nodes, now if this is the stomach again which was there, D1 lymph nodes are all the lymph nodes around the stomach, what is known as perigastric lymph nodes. D2 lymph nodes are advanced level, that has gone further along the great vessels, might be along the celiac artery, maybe along the aorta. So those are the lymph nodes along those vessels. So D2 are along the vessels, D1 are around the stomach, that is perigastric lymph nodes. So here D1 or D2, either one can be done in case of total gastrectomy. This is done again to remind in case of malignancy of the body or linitis plastica and aggressive proximal tumors of the stomach. The distal part of the jejunum is anastomosed to the esophagus, the duodenum is closed, and the proximal part is anastomosed to the distal jejunum here to maintain the continuity. So when we spoke about the lymph nodes D1 and D2, D1 is around the stomach and D2 is around the vessels. So just to simplify it, right cardia, left cardia, lesser curvature, short gastric, left gastroepiploic, right gastroepiploic, suprapyloric, infrapyloric. So these are all around the stomach. So removal of these lymph nodes up to here most of the time is what is called as D1 lymph node excision or D1 lymphadenectomy. So right cardia, the upper part, the right cardia and left cardia along the lesser curvature, short gastric, left gastroepiploid, right gastroepiploid, suprapyloric, infrapyloric. Then comes the major vessels, the left gastric, the anterior hepatic artery, the celiac artery, the splenic hilum, the splenic artery, the infradiaphragmatic, esophageal hiatus, lower esophagus and the supradiaphragmatic. These all become the second group, that is the D2 lymphadenectomy, and removal of these will encompass the D2 lymphadenectomy when it comes to total gastrectomy. So this is what is meant by D1 and D2. Then coming to palliative surgery, not always can you give a curative surgery for the patient. Sometimes the malignancy might be advanced, but the point to be remembered is that however advanced the malignancy, something has to be done for the patient to eat and then pass stools. Thereby, whatever time that the patient has, the patient can be at least with some comfort. And that is where the concept of palliative surgery comes, even in case of advanced disease. So, it is done where there is obstruction or bleeding. Removal of the tumor and gastrointestinal reconstruction may not be possible. So, roux loop with a wide anastomosis between the stomach and the jejunum is done. Anterior gastrojejunostomy can be done. Gastric exclusion and esophagojejunostomy can be done, and in inoperable tumors in the cardia, stenting can be done. So based on the location, so one is remove the tumor, advanced disease, it has already spread to the liver, but you want to maintain the gastrointestinal continuity, you want to stop the bleeding, so remove the tumor without even adequate margins maybe, and do a gastrointestinal anastomosis, just like how you would do otherwise. If that is not possible, roux loop of the intestine, jejunum is taken up and anastomosis is done with the stomach. Anterior gastrojejunostomy, you are completely forgetting about the tumor. Let the tumor be there. It is advanced. It has invaded the adjacent structure. You just want the content from the stomach to go into the jejunum. So, anterior gastrojejunostomy is done. I will show the picture. Gastric exclusion and esophagojejunostomy. So, forget about the stomach only. Do a esophagojejunostomy. Take the esophagus and anastomose it to the take the jejunum and anastomose it to the esophagus. Forget about the stomach. And inoperable tumors at the cardia where the esophagus meets the stomach, just put a stent and leave it like that. So the different types of palliative surgery here. So here there is a large tumor in the distal part of the stomach which is invading into the adjacent structure. Probably there are hepatic mets as well. So leave the tumor like that there and anastomose the stomach to the jejunum. So roux loop of the jejunum is brought there, tumor is left behind, no curative surgery is done, contents of the stomach will go into the jejunum, ileum and go into the colon. If that is one way. The other way is a loop. So here a roux loop, that is the jejunum is cut, the distal loop is brought up, anastomosed, and the proximal loop of the jejunum is anastomosed to the distal loop of the jejunum. The same thing, inoperable tumor, here, you can't remove the tumor, so the duodenum comes this way, jejunum, the loop of jejunum itself is anastomosed to the anterior part of the stomach. No other anastomosis, no cutting the jejunum distally, no bringing the distal part of the jejunum upwards. The loop itself is anastomosed to the stomach so that the contents go from the proximal part of the jejunum into the distal part of the jejunum. And here you can see the tumor also is removed, the distal part of the stomach is removed, the tumor is left behind, and a loop, the same way the loop is brought out, and this loop of intestine, especially when we talk about Roux loop, or even this one, can be done anteriorly or posteriorly. Anterior to the transverse colon or posterior to the transverse colon, where it is called as anticolic, that is anterior, retrocolic, behind the colon. So these are the different types of palliative surgeries in case of carcinoma stomach. What are the complications of surgery? So esophago-jejunostomy leak. So jejunum is brought up to the esophagus and anastomos, that can leak. Duodenal stump leak, very, very important in case of carcinoma stomach. So if we see this picture here, now forget that this is an inoperable tumor. The tumor has been removed. Even in case of curative resection, the duodenal stump has to be closed. This stump here can blow out, spewing out all the contents of the duodenum into the peritoneal cavity. It is a very important complication of surgery in case of carcinoma stomach. Colocutaneous fistula. A fistula can form between the anastomotic site and the skin. Post-operative reduced capacity. Now the stomach, the distal part of the stomach in subtotal gastrectomy or distal gastrectomy is removed. The capacity of the stomach is decreased. So patient may have feeling of reduced capacity of the stomach, and because of which patient may have malnutrition even after a curative surgery. So the complications of surgery are esophago-jejunostomy leak, duodenal stump leak, colocutaneous fistula, post-operative reduced capacity, and malnutrition. Then comes chemotherapy. So these malignancy, carcinoma stomach, they respond well to cytotoxic chemotherapy and neoadjuvant chemotherapy. Chemotherapy given before the surgery, and that is known as neoadjuvant chemotherapy. Chemotherapy given after the surgery is known as adjuvant chemotherapy. So the first line of chemotherapeutic drugs are epirubicin, cisplatin, and 5-fluorouracil. The three common chemotherapeutic drugs that are used, that is epirubicin, cisplatin, and 5-fluorouracil. The second line drugs, taxotere combinations, are now being used, and even more newer biological agent, that is trastuzumab, what is known as Herceptin, in HER2 positive tumors can be used in case of carcinoma stomach. These are the newer biological agents. So the first line is always epirubicin, cisplatin, and 5-fluorouracil. Second line treatment is taxotere combination, and biological agents like Herceptin can be used. The use of radiotherapy is very controversial because around the stomach there are a lot of organs, very, very important organs, and radiotherapy can injure those organs. So radiosensitive tissue in the gastric bed, if radiation is given with the intention of destroying the tumor tissue, it can destroy the adjacent organs as well. Palliative treatment is, that's why palliative radiotherapy is, that's why only used for painful bony metastasis, then radiation is given to those bony metastasis. Otherwise, as such, to the gastric bed, radiation is not given. So, to summarize carcinoma stomach, it is caused by H. pylori, gastric atrophy, polyps, peptic ulcers, cigarette smoking, diet rich in salts, and other genetic. Cauliflower shaped ulcerative or linitis plastica. Cauliflower shape will cause obstruction, ulcerative will cause bleeding. There are a number of classifications, WHO classification based on the histology of the malignancy. Lawrence classification is the most important clinico-pathological classification. Japanese and Borman's classification, which is characterized by whether the depth. Japanese is early and Borman's is late, and Sievert's classification at the gastroesophageal junction. Clinical features characterized by early satiety, bloating, dysphagia, vomiting, iron deficiency anemia, weight loss. The spread can be either direct, lymphatic, via blood, or transperitoneal spread. The investigations are barium study, ultrasound, CT, laparoscopy. The treatment can be endoscopic mucosal resection, total gastrectomy, subtotal gastrectomy, and this is followed by chemotherapy, which is the first line, is epirubicin, cisplatin and 5-fluorouracil. So this in brief is the clinical features